Hi, everyone, and thank you all for registering. My name is Helena Salgueiro. I'm the Digital Education Leader for MRI for the Northern Europe. And today I'll be talking about fat suppression techniques in MRI. So fat suppression has always been something that is meant to be very basic, but it is very hard to get it right. And it affects so many types of scans, and it's so relevant for our clinical applications that I thought this could be a good topic for us to explore and have a bit more knowledge about it. That's why I put this presentation together. So I will invite you all to go through the presentation with me. If there's any questions, please pop them onto the chat box. I will try and answer as much as I can, depending on the volume of questions as well. But if I don't manage to answer your question on the chat, please feel free to drop them into GE Cares afterwards. I will give you the contacts for that. In this session, I will give a technical overview of the fat suppression techniques used in routine clinical examinations and ways to optimize them. I will be focusing on fat suppression only, so other suppression techniques such as water suppression will only be briefly mentioned. So during this session, I will identify the clinical needs for fat suppression in MRI, discuss the challenges to achieve optimal fat suppression, explain the different fat suppression techniques available in GE, and recognize the advantages and disadvantages of each technique and how to optimize them. So by the end of this session, you should be able to identify the main difficulties in achieve optimal fat suppression in clinical practice, know the different fat suppression techniques available, and how to optimize them. So why do we need to suppress the fat signal? There are various reasons to do such as tissue characterization. So for example, to visualize bone marrow lesions, evaluate the fat content in soft tissue masses, to better visualize the structures of interest as the fat tissue may be obscuring the area, for tissue enhancement after gadolinium injection, or to reduce fat-related artifacts. The key point is to know why your exam needs fat suppression so you can evaluate, first of all, if it was successful, and also to select the best technique for the specific exam you are performing. So now let's have a look at which clinical areas or anatomies do we routinely apply fat suppression. As we can see, fat suppression is applied to basically all anatomies and clinical areas, and also, as you can notice from the examples shown, is applied to a wide variety of sequences from fast spin echo, T1, T2, PT weighted, LAVA, 3Ds, propeller, time of flight, or DWI. And in some cases, it can also be combined with other saturation techniques to achieve, for example, fat and water suppression simultaneously. Regardless of which FATSAT technique that we are using, the challenges are all related to inhomogeneities of the B0 and B1 fields. This can be caused by presence of metal, either inside the patient's body or in their clothing, off-centered anatomy, for example, areas with very different interfaces, for example, the neck, where the interface between the neck and shoulders is always a challenge for FATSAT. Non-optimized sequences in technique, so for example, choosing the wrong inversion time or not applying a shim. There can also be technical issues like gradient or shim deficiency. And that can be also external interferences. So for example, medical equipment like injector pump or any sort of Faraday cage compromise, or even something simpler like the scanning door isn't closed properly. So all of that will cause interferences with our fields. So how do we achieve fat suppression in MRI? To suppress the fat signal in MRI, we rely on the differences between the fat and water protons. These protons behave differently regarding the chemical shifts. So by knowing the difference in resonance frequencies between fat and water protons, we are able to apply specific RF pulses to null the fat. The frequency is different from 1.5 and 3T, as we can see in this PowerPoint. And the other difference is the T1 relaxation time. The T1 relaxation time of fat is different to the water, and knowing this will allow us to apply inversion pulses and then acquire when there's no signal coming from the fat tissue. So knowing the principles behind fat suppression, we can now categorize the options available in GE according to the graphic. So relying on the chemical shift, we have spectral fat saturation and Dixon. Then relying on the T1 relaxation time of fat, we have the stir sequence. So let's start by looking at spectral fat saturation. So this technique is based on the chemical shift methods. RF pulses are tailored to excite protons in a particular resonance frequency range. This range can be narrowed so that the RF pulse affects only water or only fat, unlike stir, where we're going to see a bit further ahead, where all the magnetization gets inverted. During the acquisition, a frequency-selective SAT pulse with the same resonance frequency as that of lipids is applied to each slice. A spoiling gradient pulse is applied immediately after the SAT pulse to dephase the lipid signal. The signal excited by the following slice selection pulse then contains no contribution from fat. In GE, we can select from two options, fat and fat classic. The difference between fat and fat classic is the saturation strength. Fat applies a stronger saturation, which leads to a more black and white image, where muscle tends to be suppressed as well. Both techniques have their clinical value and are selected according to the radiologist's radiographer preference. So, for example, a PD fat sat for MSK tends to be on fat classic, so the muscle doesn't get suppressed, while post-GAT T1 fat sat for gynae pelvis, for example, tends to be on fat. The other option for spectral fat suppression is the special. So special stands for spectral inversion at lipids, and this technique uses a spectral selective adiabatic RF pulse to invert only the fat signal. It starts by applying an inversion flip angle pulse of 180 degrees to a segment of KZ lines with a long TI. The image acquisition starts at the inversion time when the fat signal is at the null point. In this case, the TI is not selectable as it is automatically calculated for us. Once again, unlike what's going to happen with stir, and we're going to see that further ahead. So the spectral inversion is more selective than the fat or fat classic options and provides a more robust saturation. So this would be a good option for challenging anatomies such as liver or breast. However, it tends to have longer scan times than the fat or fat classic options due to that extra inversion pulse that we're giving here. So what are the advantages of this type of fat suppression? First of all, it's relatively fast when compared to other fat suppression techniques. The fat efficiency is adjustable either by selecting fat or fat classic, or in the advanced tab, we have the option to select the fat suppression strength, as we can see on that image. Reduces the chemical shift artifacts. Is available for all contrast weightings and compatible with most sequences as well. It doesn't affect the tissue contrast and can be used after contrast media injection. And what are the disadvantages? So first of all, it's very sensitive to B0 and B1 in homogeneities. The SNR in fat tissue decreases. Increases the scan time when compared to non-fat sat suppressed sequences. And the optimization requires operator knowledge. And what are the applications for spectral fat saturation? So this technique is compatible with most sequences, as I've mentioned before, and is used for all clinical specialties. But some of the main applications are post-contrast or arthrograms, because it doesn't affect the contrast. Enables to identify fat by its dark appearance in fat-suppressed images, can reduce breathing and wrap artifacts for body, and reduces chemical shift artifacts in MSK. So how can we optimize this kind of sequences? So by adding padding between the patient and the coil to prevent contact areas or gaps. We should scan as close as possible to the isocenter. So in theory, fat saturation is only guaranteed up until 20 centimeters off of the isocenter. So if we think that will be 20 centimeters either side of the isocenter, which gives us a 40 centimeter field of view. And this is why when we go for bigger field of view, so over 40, we start having some fat sat failures at the edge of field of view. Another way that we should always use, and we should always make sure we apply, is a shim volume for these kind of techniques. We should also choose the best type of ChemSat for the anatomy. So as I've mentioned, we have the fat and fat classic and the special. So if we are performing breast, if we are performing even a neck or any anatomy that we know it's going to be challenging and we have the option to select special, we should go so. And at last, and in some cases, we might need to perform a manual pre-scan. So when we perform a manual pre-scan, we are given this kind of graph. And in that graph, we will be able to center frequency at the point that we want to allow for fat sat. So in this case, we will have the first peak on the left will be the water peak. The peak in the middle is the fat. And because we have silicon present in this image, the third peak on the right is the silicon. So if we didn't have silicon in the image, all we were going to have would be the water peak and the fat peak. And then we would be able to drag the line into the center frequency we want and apply. If you have access to GE Cares, I would highly recommend to search for our shimming and manual pre-scan guide, or you can just scan the QR code in your screen now, and you'll be able to get more information about that after. So now let's have a look at inversion recovery. This relaxation-dependent technique is based on the different relaxation behavior of water and fat tissue. Fat has a much shorter T1 relaxation time than other tissues. The STIR technique, that stands for short tau inversion recovery, uses a 180-degree inversion pulse as an initial excitation pulse, which inverts the spins of all tissues. So this is not a selective pulse to fat. This will invert both fat and water. The tissues perform T1 relaxation time. The longitudinal magnetization of fat recovers faster than that of water and crosses the zero line, so the no net magnetization, after an inversion time. The application of a 90-degree excitation pulse at the time a fat signal crosses the null line produces a fat-free signal image. The time between the 180-degree inversion pulse and the 90-degree acquisition is the TI, or our inversion time. Tissues with a T1 relaxation time different to fat will produce signal because they either have not yet reached the null point or have recovered past it. So what are the advantages for STIR? It's very efficient and homogeneous fat suppression, very good for large field of views as well. It's very robust to B0 and B1 in homogeneities. The fat efficiency can be adjusted by adjusting the TI, and is available for PD and T2 weighted images. And what are the disadvantages? So long acquisition compared to the chemical fat sat, due to that inversion time that we have to allow into our TR as well. It has low SNR, So we need to, in most times, either increase nex or reduce our acceleration so we don't have a very noisy image. It's more sensitive to flow and motion artifacts. It's not available in T1 weighted and is not possible to use after contrast media, and that is because we're using a non-specific inversion pulse. So by using a non-specific inversion pulse, we risk that the pulse will also null the signal of contrast. So what are the main applications? As I mentioned, for large field of views, is very efficient around metal, provides a more homogeneous suppression of isocenter imaging, and is very good around air tissue interfaces. So again, neck area kind of way. How can we optimize this technique? So first of all, we need to adjust our inversion time. So this is different from 1.5 to 3T. So at a 1.5, we usually use a TI in the ranges between 140 and 170 milliseconds. And for 3T, 180 to 210 milliseconds. As mentioned as well, we can have low SNR, so we should optimize our parameters to improve that, increase nex, reduce acceleration. And in the advanced tab, we should use the enhanced fine line suppression CV user. So now looking at the Dixon techniques. Dixon is an umbrella-like term that is used to describe multiple different techniques of fat and water separation, which are also based on the chemical shift methods. Dixon techniques acquire in-phase and out-of-phase images and use them to create fat-suppressed and water-suppressed images. So the way it works, first acquires images at 3 different echo times when water and fat are at 30 degrees, 90 degrees, and 210. Then, using an interactive decomposition of water and fat with eco-asymmetry and least squares estimation, is able to separate the water and fat signal and reconstruct up to 4 different image weighting: fat, water, in phase, and out of phase. Fat and water will always be reconstructed by default, and we can select whether we want in-phase and out-of-phase reconstructions as well. In G, we have the options of ideal, which is a 3-point Dixon technique, and flex, which is a 2-point Dixon technique, so only 2 echoes are acquired. Because we acquire more information with the ideal, this is a more robust technique than flex. However, it has longer scan times associated as well. So what are the advantages of Dixon technique? It has increased SNR due to the multiple echoes that we acquire. Is very robust regarding B0 and B1 heterogeneities. Allow us to acquire multiple contrasts created within one series. So basically, if we are acquiring a scan that requires T1 and T1 FATSAT, we don't need to do 2 separate acquisitions, we can do all in one. Is available for T1, T2 and PD weighted, and can be used after contrast media injection. And what are the disadvantages? We cannot control the fat efficiency, so it will always be displayed as is. It has longer scan times than FAT or FATSAT or STIR. It has the potential for fat water pixel swap artifact. So when that happens, it will completely invert. So the fat suppression will be water and the water will be fat. And that can happen in the whole series, or that can happen in part of the image. So for example, when scanning thighs, one side can be in fat suppression and the other side can be in water suppression. It is very tricky and is very challenging to reduce that. However, there's a few things that we can do to try and minimize that misregistration between fat and water. So one of the things is ensure there's no wrap in the image. So ensure our field of view covers the whole anatomy, or that we use no phase wrap accordingly. We should also avoid air tissue interface changes or just adapt our field of view very well to our anatomy. And do not image in the presence of motion. So it is more likely to have a fat water swap if there's motion in our image. The main applications for the Dixon techniques are where we are scanning challenging anatomies. So it is very good for different interfaces, so neck and shoulders, and is also very good with metal, as we can see on images represented here. The other advantage is that we produce multiple contrasts with one acquisition. So how can we optimize both ideal and flex? Again, add padding between the patient and the coil. Apply a shim volume, again, because it's a chemical saturation based technique. Optimize parameters to reduce blurring for ideal, so increase our resolution, increase our nexus, and optimize parameters to avoid pixel swap. So as I mentioned beforehand, adjust the field of view, ensure our image is optimized in that way. So now let's have a look at some examples. The image on the left, we are using chemical fat sat, and as we can see, it is failing in the neck-shoulder interface. The image on the far right, we are using flex, which seems to have resolved the failed fat sat at the shoulders. But when we compare to the image in the middle, where we are using ideal, we can see how much more robust the fat sat is. The scanning time is also a bit higher when we use ideal. So with the flex it was 2 minutes 21, and now with the ideal we have a 3 minutes 17. However, then we need to think about, as I mentioned first thing when we started this presentation, think about what we need to see, what is more important for me, whether to have more information and have a slightly longer scan time, or have a faster scan with less information and a bit more fat sat failure. And now an example of abdominal imaging using lava. So the image on the left, we are using chemical fat sat, and we can see how the fat sat is failing at the edges of the field of view, and that's because we're using a very big field of view. The next image, which we are using lava, it has resolved that fat saturation failure at the edges of field of view. And then we have an example of lava flex at 1.5 and 3 Tesla as well. So as takeaway messages, we should think about that robust, uniform fat suppression is essential for quality MR imaging examinations. Best technique is dependent on several factors. Recognize fat sat fails and artifacts is essential to then be able to minimize them and optimize, and then take steps to optimize techniques. Thank you for your attention. And once again, if you have access to the G-Cares, that will have a lot of information, quick reference guides on fat sat, and this presentation will also be available there as a replay afterwards. Okay, thank you everyone for staying here through the presentation. So let me just have a look at the chat and see what we can do. So yeah, would certificates be issued? Yes, they should be sent to the email you've registered with for this webinar. Then can you please throw more light of difference between fat and fat classic? It's mainly, as I mentioned in the presentation, is just the fat saturation strength. So there's not much difference in scanning parameters. There's not going to be much difference in terms of scanning time, for example. It's just the strength of that SAT pulse we're sending. So for fat classic, we're saturating less than for fat. So it's just going to be a way of your image, how your image is displayed afterwards. So I hope that answers the question. How to overcome the ideal breathing artifacts? Well, as any other technique, I'd say, yes, ideal, and all the Dixon techniques are quite affected by motion and breathing artifacts. But again, it will be the same as any other technique. So you have to either do breath holds, do breathing or tracking. There's not much, you're not likely to be able to do an ideal breath hold just because of the scan time. That's why lavas tend to be flex and not ideal, because they're a little bit quicker. But yeah, I would say just as any other technique to reduce the breathing artifacts. You won't be able to download the recorded version. It will be available on GE Cares, and because you have watched the live presentation, you will receive a link with the replay so you can watch it. When I say padding, what do you exactly mean? So padding in a way, as you would do normally, first of all, to protect your patient from burnings, but also to ensure that the coil is as fitted to the anatomy as possible. So if you are using a dedicated coil, you should pad so there's no air between the patient and the coil. Same with the body coil, or if you're using the flex as well. Okay, many thanks. Thank you, everyone. Okay, another question about padding. During neck imaging, how can we do that, please? Okay, so good question. And obviously neck is such a challenge anatomy. Most of the times using just the head and neck unit, you will be able to acquire a good coverage for the neck. So in that case, I wouldn't say you need to add any extra padding, because you're just going to have the neck unit that comes all the way to shoulder length, unless you go for a bigger coverage that you need more sort of like brachial plexus kind of coverage, where you're probably going to add either the body coil or the flex coil to cover the chest. Then in that case, as long as the coil is closer to the anatomy, I don't think you need any extra padding. So another question, how should I recognize fat sat failure? Well, that's exactly when we started, that I've mentioned is good to know what you are trying to achieve with your scan. So knowing the anatomy that you're scanning is mandatory. So then you see a non-fat sat image and you compare with the fat sat image, and you know what failed and what should have been saturated and not. So basically by knowing your anatomy, really. There's quite a lot of questions now, so I think I'm going to just filter a couple of them and see if there's a few that I can answer at once. Okay, so that's a good one. Do you recommend putting pads under a slim patient so they are central to the core inferiorly and superiorly? So I think you mean, so they're exactly in the center of the bore. So I would probably say no, because then you are increasing the distance from the table coils. So you're going to lose signal that way. So no. Fat suppression on high BMI patients. It's challenging, and that is mainly because of the big field of views that we are using. So, and for those kind of patients, you probably would like to go probably for stir or the Dixon techniques, just because you're not going to have as much fat saturation failure at the edges of field of view, just because you're going to apply a big field of view for that kind of scans. Is there an app for GE Cares? No, it's all web-based, but you can access on your phone as well. But no, there isn't an app, it's all web-based. if patient has metal, can I use a PD ideal to get saturation? Yes, yes, you can. It will probably, again, you will need to spend a little bit more time acquiring. But yes, it is very robust when you use with PD. For example, I'm sure that's what you mean when they have for MSK and they have any sort of implants. Yes, it is good. And I will maybe select one or two more. So what's the, okay, let's talk about breasts. What's the difference when we use vibrant sequences to breasts comparing to flex or ideal? So vibrant tends to be flex sequences or with chemical fat sat. Not quite sure what were you trying to get with that question. I feel like flex tends to work really well, and in terms of a compromise between, you know, scan time and image quality, it is quite good. Especially when compared with normal chemical sats, flex very rarely fails unless it fully swaps. But in that case, you'll still have your reconstruction in another series. And I will, let me just forward. Okay, and I think I will finish with this one because it's quite an important one. Fat water pixel swap artifacts. Please, can you tell us again steps taken to avoid the artifacts? This isn't gonna magically work 100% of the time. It is very challenging because Dixon works amazingly when it works, and when it doesn't, there's not a lot that we can do and that we can control, especially beforehand. But the main things are to ensure you don't have any rep in your image. So either increase your field of view or apply no phase rep, just to ensure you don't have that. I would say, and because it's still based on chemical saturation, apply a shim box as well for the whole volume, and avoid having a lot of air outside of your field of view, in your field of view, so outside of your anatomy as well. So I'd say for me, what works the best to avoid that fat water swap is to actually adjust the field of view very, very well, not having it too big and not having it too small to create wrap, and then have a shim box to cover the whole anatomy. Okay, still quite a lot of them. So unfortunately, I won't be able to answer all of them. I will then, you will be able to, through GCares as well, you'll be able to submit questions there. And I will be more than happy to answer them afterwards. Once again, thank you all for joining today. And I will see you next time in the next webinar.